Dr. Baliga here. This podcast is a multiple choice question preparation for the boards from an outstanding chapter titled Perioperative Medicine in Baliga's textbook of internal medicine, available at mastermedfacts.com. The chapter is authored by Dr. Hugo Quinny Cheng, MD, who is professor of medicine at UCSF. He also completed his medical school and residency training there. He works as a hospitalist with a clinical focus on perioperative medicine. He also directs the Internal Medicine Board Certification and Recertification Review CME course for UCSF's Department of Medicine. A 72-year-old man with chronic obstructive pulmonary disease will undergo open repair of an abdominal aortic aneurysm. He uses an ipratropium meter dose inhaler as needed for dyspnea. He reports mild dyspnea on exertion and a cough that produces minimal amounts of white sputum. These symptoms have been unchanged for the past 6 months. He quit smoking 2 years ago. Which of the following actions is most likely to reduce his risk of postoperative pulmonary complications? A. Start doxycycline. B. Start prednisone. C. Change as needed ipratropium to every 6 hours. D. Obtain preoperative pulmonary function tests. And E. Encourage use of an incentive spirometer. And the answer is E. Pulmonary function tests are unlikely to improve risk stratification or perioperative management in patients with known COPD. Given that the patient's COPD appears to be at stable baseline, there is no indication for starting prednisone or antibiotics to treat an exacerbation. Changing the ipratropium inhaler from as needed to fixed dosing is not indicated. Lung expansion maneuvers, such as use of an incentive spirometer, has been shown to prevent pulmonary complications. Reducing risk of pulmonary complications. The strategies to prevent postoperative pulmonary complications have not been studied as thoroughly as those for cardiac risk reduction. Patients with obstructive lung disease should have respiratory status optimized prior to elective surgery. Smoking cessation prior to surgery has uncertain benefit. Retrospective studies found that the risk of postoperative pulmonary complications in smokers can be reduced only if they cease smoking for at least 1 to 2 months prior to surgery. Due to the role of lung collapse in postoperative pulmonary complications, use of lung expansion maneuvers, example deep breathing exercises, or incentive spirometry, is recommended for high-risk patients. This short case scenario is from an outstanding chapter titled Perioperative Medicine in Baliga's textbook of internal medicine, available at mastermedfacts.com. The chapter is authored by Dr. Hugo Quinny Cheng, MD, who is professor of medicine at the University of California, San Francisco, where he also completed his medical school and residency training. He works as a hospitalist with a clinical focus on perioperative medicine. He directs the medical consultation service and co-management with neurosurgery service and regularly teaches about preoperative medical evaluation, perioperative medicine to residents and practicing physicians. He also directs the Internal Medicine Board Certification and Recertification Review CME course for UCSF's Department of Medicine.